Awesome. So hi, everyone. My name is Maddie. I'll be presenting today on our topic, perinatal mental health, considerations for families. For those of you that are in the field, you are probably familiar with the topic of perinatal mental health. It's kind of a term that has changed over the years. We used to talk about postpartum depression, or we would talk about maternal depression. In recent years, we've kind of expanded that definition to talk more about the perinatal period or the peripartum period. We will be defining like, hey, what's the difference here as we get into it today? But our focus will be specifically how these perinatal mood and anxiety disorders impact families, and in particular, the family system. So before we get into it, here is our agenda. Today, we're going to be defining perinatal mental health. We'll be exploring the mental health implications of becoming a parent, both for the person who gave birth and for the non-gestational parent for different parts of the family system. We'll be describing the impact of the perinatal period on the system, not just on each member, but on the dynamic within it. And we'll also be identifying strategies for engaging with parents and families during the perinatal period. So we're going to be taking a pretty broad overview of this, this topic, the perinatal period, and how it can be impacted by mental health. And then we'll be applying it specifically to our work with parents, couples, and families. So a quick note on language. You'll notice even in our first couple of slides that I am using terms like birthing person, pregnant person, parent, and non-gestational parent. Not everyone calls themselves mom or dad. I call myself a mom. I have a 1-year-old. That's a term that I'm comfortable with. When it comes to my clients, they might not, even if they are the person who gave birth, even if they are female identified. And so for the purposes of this presentation, I am going to use less gendered language. This might make you uncomfortable. Let's sit with that. I would like to encourage us to be curious today. I know that sometimes when I'm sitting in a CEU, I am a little bit, I guess, disquieted, uncomfortable, confused, antsy when I come up with something that conflicts with what I previously thought or what I previously believed. And typically when I am open to learning more about it, when I get curious instead of putting up a wall, that's when I learn the most. So I would encourage you all to do the same. And for clarity's sake, when I'm talking about the person who gave birth or the birthing person, I will typically be talking about some of the physical, biological, medical impacts of having been pregnant and having gave birth, versus when we're talking about the non-gestational parent, we will be talking about some of those more social, cultural, situational aspects. But language is important, and that's why we're starting here. A little bit about me, since I just yammered on about our presentation and our agenda today, just so you know who is it that's talking to you. Like I said, my name is Maddie. I use she, her pronouns. I'm a therapist in solo private practice in Cleveland Heights. I have been a social worker since 2016. I've been at the master's level since 2017. I did a certificate in sexual health from the University of Michigan and am like 90% of the way done with my training to be a certified sex therapist. In my practice, I typically see LGBTQIA+ folks. I see a lot of perinatal mental health clients, so people who are family planning, trying to conceive, pregnant, postpartum, or just parents of little kids. I do a lot of couples work, and I also see a good number of anxiety disorders. So that's a little bit about me. First things first, we should probably talk about we should probably talk about what this topic is and get some common definitions. What exactly is perinatal mental health? So the term perinatal means all around birth. So this is the period from conception through pregnancy, through birth and baby's first year. For some people, this might include the preconception period or trying to conceive, such as if people are going through infertility treatments or if they have any family planning stuff that they are working through that impacts their mental health. So, as a perinatal mental health provider, I have clients who are pregnant. I have clients who have given birth recently. I have clients that have little ones that are 6, 7, 8, 9 months old. But I also have some couples that are in the immediate thick of talking about having kids, who are doing family planning, who might be doing things like the pre-testing for fertility treatments. That could be a whole other presentation talking about the impact of trying to conceive on mental health. But the big picture here is that the perinatal period is a lot longer than just pregnancy and immediately after birth. Um, Often, when we hear from people who have been pregnant, we hear about that 6 week checkup, that 6 week appointment where you are following up with your OBGYN. And at that appointment, they say, great, you can exercise, you can resume normal activity, everything looks good. See you in a year for your annual visit. That is where we thought up until the last 10, 15 years or so that the perinatal period started and ended is when you get pregnant to when your OB signs off on you going back to the gym. Um, Clearly, in the years since, we've learned that it is much broader than that, that there's a whole familial and personal and emotional and physical transformation that affects not just the person who gave birth, but also their co-parent, also their family system, and it has a big impact on the life that they live. So the perinatal period, all around birth. In this presentation, we'll be talking about PMADS, which is an abbreviation standing for perinatal mood and anxiety disorders. PMADS are kind of an expanded definition to include more than just postpartum depression. It can include postpartum anxiety, bipolar disorder, OCD, PTSD, and postpartum psychosis. We'll get into it a little bit more later about the prevalence of these different PMADs, but when these mental health symptoms start to emerge in the perinatal period, they are often influenced by the factors. They're often influenced by factors related to the perinatal period versus when they happen outside of it or in people who don't have children, then the cultural, social, physical aspects of the perinatal period are unrelated to the diagnosis. So in short, before we used to think if somebody has postpartum depression, must be the hormones. Once your hormones regulate, it'll go away. Once you wean from breastfeeding, your mood will stabilize again. Once you start getting regular sleep, you'll start feeling like yourself again. But what we have learned is that that is not always true, that it's more than just hormonal changes. Like, yes, sleep and nutrition and hormonal health are all really important parts of healing PMADs from treating them, but also there are different factors that simply are different after you have a child, after you add a child to your family. So how common are PMADs? Like, just how frequently are we talking here? About 1 in 7 people will experience postpartum depression after giving birth. 6 to 8% of people who have delivered children in the last 6 months will experience postpartum anxiety. 2 to 9% will experience postpartum PTSD. Up to 4% of people will experience postpartum OCD, and 1 to 3 people in 1,000 live births will experience postpartum psychosis. And so what this looks like is after somebody has given birth, or sometimes in the perinatal period during pregnancy, if somebody has symptom onsets for these different conditions, they would be counted as part of these prevalence statistics. And this is information from the American College of Obstetrics and Gynecology. So it is relatively accurate to the US population. Just to drive this point home a little bit further, PMADs are the #1 post-birth complication. For anyone who has given birth or known someone who has given birth, people love to share their birth stories with other parents, which is both a really beautiful thing and can also be a really anxiety-provoking thing when you are about to do so yourself. Um, you always hear about the complications physically that people have, I think in part because I'm a mom and we love to take care of each other. We want to protect others from going through the horrible things that we have gone through, or I don't know, look out for each other in that way. Beautiful instinct, also really scary. But the one thing that we don't do a good job talking about as a culture, as a community, is the prevalence of postpartum depression, anxiety, and other PMADs, especially when they are so, so common. You get this kind of questionnaire when you go to the OBGYN about, it's called the Edinburgh postpartum depression scale or maternal depression scale. It is a validated screening instrument for postpartum depression, but the questions that it asks are very clinical. It's things like, are you able to eat and sleep and take care of yourself and take care of your baby? And if you're doing all those things, great job. Must not be anything wrong. But we know that PMADs are often occurring outside of what we are screening, that the rates detected by that instrument are not accurate to what is actually happening in real people's lives. Never mind the fact that we are only screening people who have recently given birth. That doesn't include adoptive parents. That doesn't include non-gestational parents. PMADs are happening way more often than we know about. And then kind of a very serious statistic, PMADs are actually the #1 cause of maternal mortality in the United States. So when left untreated, postpartum or perinatal mood and anxiety disorders can be quite dangerous and can be fatal. So it's about time that we take this perinatal mental health crisis seriously in the United States. So what are the risk factors for PMADs? There are quite a few. I was just talking about this last night with a friend. The risk factors that we look for typically fall in a few different buckets. For psychological risk factors, if someone has a personal or family history of mental illness or mental health symptoms, then they might be more likely to develop PMADs during pregnancy. If somebody has an unplanned or undesired pregnancy, or if they've experienced abuse in their lifetime, they're leading up to or during their pregnancy. And again, these are risk factors. These are not a guarantee. So if somebody has a prior history of postpartum depression, anxiety, OCD, that doesn't guarantee that they will have it with subsequent pregnancies, but it does mean that it is a risk factor. And so as providers, we should be keeping our eyes open and paying extra close attention. And I would go as far to say as even making a plan to cope ahead. There are also some obstetric risk factors. So if somebody has delivery complications, if their expectations of birth are different than their reality. So if they are if they have the intention of giving birth unmedicated, for example, if they really want to experience an unmedicated birth, but then at the time that they deliver, they aren't able to, they need medical intervention for some reason. If somebody has a history of prior birth trauma, whether that be um, a difficult delivery, a complicated delivery, if they have prior NICU experience with an older child, if they have a history of perinatal loss or termination for medical reasons, or if they have a prior history of a PMAD. Again, it's not a guarantee that that person will have one again in later pregnancies. There's about a 50 to 75% reoccurrence rate. So it is on the higher side, but I do also think that there needs to be more data collected about symptom focus and severity, or I guess intensity, frequency, amplitude, all the things that we're using to describe mental health symptoms when they occur. So if somebody has severe postpartum anxiety, let's say with their first pregnancy, we need more information on how likely is it that that will occur again in a second pregnancy? How intense will it be? How frequent? And how are they coping? How does it affect their life? What do they need to do to keep themselves well and take good care of themselves? Other risk factors, biologically younger age is associated with greater risk of PMADs, typically folks that are in their teens or early 20s. The hormonal changes and how they affect a person, and also low serotonin. There is a really severe drop in serotonin that occurs with breastfeeding, and also hormonal changes. Again, every person who gives birth experiences the high highs of estrogen and progesterone right before delivery, and then the subsequent drop that occurs after birth. So the different hormones and different neurotransmitters in your body are going up and down on a roller coaster for those first couple of weeks. And again, as you're breastfeeding or pumping, and certainly by the time that you're weaning from that, you're experiencing greater levels of prolactin and oxytocin, the things that make breast milk. That can be very impactful on mood as well. Social risk factors, if somebody has low social support, meaning if they don't have close family, friends, neighbors, people that they can talk to or lean on. It's also pretty common for new parents, whether they've given birth or not, to feel a sense of isolation from their peers without children. This is a thing that I hear about a lot in therapy, that it can be really difficult to reconnect with those friends, feeling like my whole life is so different than it was a few weeks ago. How do I fit back into those rhythms and routines? If somebody is experiencing domestic violence or relationship instability. And then there's also a newer factor. Since 2020, the isolation of the pandemic has really impacted new parents and new families as well. Even in 2025, we still see a good amount of social influence caused by the COVID-19 pandemic. So if, for example, somebody is home, their family is far away, and they need to travel to come see them after birth, they want to see the new baby, the new family, are they able to quarantine? Do they have a job that gives them time off to do that? Are they in an area with masks or vaccines available? Is this something that's even on their radar? You have this new little person with a very weak immune system, and as a new family, you want to protect them, but it's not always possible to do it perfectly. And how does that impact mental health? That might be a risk factor as well. And lastly, there are lifestyle risk factors as well. Things like dietary habits, nutritional deficiencies, sleep, physical activity. These all impact our mental health. And as I'm sure you're all thinking, all of these things take a hit when you have a new baby at home. Um, I definitely was not eating my best after my daughter was born. I was not exercising. I certainly wasn't sleeping. All of these things affect our ability to regulate mood, our ability to problem solve, to cope with psychological distress, and can raise some of those biological markers of anxiety as well. If you're not sleeping well, you are more prone to higher blood pressure, to uh, higher heart rate, to lower respiratory rate. Your body doesn't feel good. Your body feels anxious. So all of these things that are stressed by the care for a new person are things that can then impact not just your physical health, but also your mental health. So you might be thinking, man, this period of life sure seems like it is uh, quite difficult for your mental health. And you would be right. When we work with clients that have new children or clients that are preparing to deliver, we need to be thinking about these things, about just how all encompassing this period of life can be. So, some common symptoms for us to be looking out for: feelings of guilt, shame, and hopelessness, racing thoughts, changes in appetite and sleep, intrusive thoughts, we'll define that, and difficulty bonding with the baby. So, intrusive thoughts, these I would define as thoughts that occur involuntarily and that are difficult to make go away. They are often unpleasant. They often don't align with your values or what you believe, but they are really sticky, and they often are about things that feel very important to you. So I don't have a prevalent statistic for this. I wish that I did, but just colloquially, intrusive thoughts are a very common experience in the perinatal period among both gestational and non-gestational parents. So these would be things like, I'm carrying my baby across the threshold into another room of my house, and I have the thought, what if I hit their head on the door frame? Obviously, that provokes the feeling of fear, of maybe anger. Why would I think that? Of disgust. Oh, I can't believe I had that thought. And even anxiety about, do I really think that's going to happen? Do I want that to happen? Why would I have that thought? Now, intrusive thoughts are often one half of what we're looking for when we diagnose postpartum OCD, but intrusive thoughts alone are not enough to amount to a diagnosis of OCD. When somebody has obsessive compulsive disorder, they have both obsessions and intrusive thoughts about that topic, and also compulsive behaviors. So in postpartum OCD, that might look like somebody having the thought obsessively, so at a really great frequency about what if I hit my baby's head on the door frame? And the compulsion might look like, I am just never going to leave the room with them. I'm always going to make my partner carry the baby from one room to the next. Or when I do go through the door frame, there are certain movements that I can make to make sure that it's safe. I'm going to tap both sides of the door frame with my hand, or I'm going to cover their head with my hands to make sure that they're safe. So intrusive thoughts, we're always looking for them when it comes to screening for PMADs, but intrusive thoughts alone are not enough to diagnose a PMAD. Lastly, a note about this: it is pretty common for people in the perinatal period, for new parents to experience guilt, shame, and hopelessness and difficulty bonding with the baby that to a person on the outside might seem inappropriate, might seem like uh, this is totally out of left field. You feel way more guilt or way more responsibility for this thing that you're worried about than is appropriate for the situation. One of the keys that we would look for in determining if this is appropriate or if this is symptomatic might be, does this person have buy-in to that guilt, shame, or hopelessness? So for example, if I am the client and I have guilt about not being a good mom, no person can convince me that I am a good mom. No person can provide enough evidence to make me feel like I am wrong about this. If I am really, really convinced of this thought, then what I might be saying to my friends, to my partner, to my therapist even, might be just brushing them off. Yeah, sure, okay. Um, yeah, I know that a good mom is someone who tries their best and who worries about their kid and wants them to be okay, but um, I guess that just doesn't apply to me. Or would a good mom really be having some of these thoughts and feelings that I'm having? Um, Another thing to kind of screen for that might present differently than what we were led to believe, if somebody has appetite changes or sleep changes, part of this might be due to taking care of their new baby, whether they were the gestational parent or not. This might mean that they are eating less frequently, or they're sleeping shorter stretches, or that they're eating way more than they normally would be, or that they're exhausted all the time. While these are explained by the situation that they're in, we still need to be screening for the impact on their mood, on their anxiety, and how it disrupts their functioning during the day. Like, yes, our culture has really normalized this idea of new parents sacrificing everything to take care of their new little ones. But does that mean that it is normal? Does that mean that it is acceptable? In a perfect world, is that what we would want for new families? That they're, eating a toaster strudel every 24 hours and sleeping 30 minutes at a time? Probably not. So again, these symptoms, they look uh, they look different in the perinatal period than they do outside of it. There's also a huge identity shift that happens during the perinatal period. And this is, I would argue, specific to women and specific to women who have given birth. This is kind of an emerging stage of, it's emerging research about this new stage of development. It's called matrescence, came from the field of anthropology and has kind of expanded into psychological research as well. But what we have found in recent years is that in women who have given birth, there are changes to the brain's structure and function, which is interesting. It means that uh, your brain works differently than it used to, and that the way that you think about things cognitively is different. The way that you problem solve is different. Matrescence refers to this psychological adjustment process that is preceded by the changes in your brain from pregnancy and also the identity shift of motherhood. So while every person, every woman who gives birth goes through matrescence, not everyone experiences a PMAD. The key thing here is that when you work with new mothers in particular, all of them are going through this identity shift phase. There is always something in that shift for us to grab onto as therapists, social workers, counselors, to help the client, to work on that adjustment. Not all of it will be clinical. Not all of it will be at the level of a perinatal mood and anxiety disorder. It's still important, it's still worthy of support, but it is different for every person. So when we talk about the identity shift of motherhood in particular, we're talking about not just the psychological piece of I feel differently than I used to, or I think differently than I used to. We're also talking about the social shift of motherhood as well. I relate to people differently. One common thing that I hear from my clients is I think about how every person was a child once, every person has parents. I feel empathy in ways that I didn't before. I feel emotions differently than I used to. One of my good friends was just saying to me last night that when she's out in public and she sees another family, she immediately has them in her peripheral vision of if I need help, I know that that person is there. Or if they need help, I want to respond. If I see them drop their wallet or drop their pack of wipes, then I'm the first to pick it up. And again, this is not something that my friend or I or any of us would have necessarily registered before that mental shift of motherhood. Um, so again, this is an interesting and emerging field, the study of matrescence. Not all of it rises to the level of what is clinical. So if there's one thing that you take away here, it should be that emotional changes after birth are normal, whether you gave birth or not. Your mood is going to be more labile. Your anxiety is going to be more labile as well. Being sleep deprived, being hungry, not feeling like yourself, all very normal. But even if it is subclinical, even if it is just the baby blues, which we'll talk about, new parents still deserve our support. There's cause for concern when the emotional changes after birth start to affect your ability to function or become overwhelming. All that means is that the support that in a perfect world you would already be getting needs to rise to a greater level to support you. In my mind, that 6-week postpartum appointment that new parents have wouldn't just be a physical check to see if you're healing after birth and if you can like run and drive a car again. It would be way sooner, maybe like a week after you leave the hospital with your new little one. It would involve the whole family and it would ask questions like, are you guys sleeping? Are you eating? Is anybody around that can help you with those things? How do you feel leaving the house? How do you feel being at home? Do you have access to the things that you need to be well? And what are those things that you don't have? How can we support you in attaining them? So you might be thinking, like I mentioned on a previous slide, well, hey, isn't that just the baby blues? And this is something that I do feel like we do a good job of warning people about, is the common temporary experience of mood lability in the immediate postpartum period. This affects about 60 to 80% of people who give birth universally, and it is typically due to the hormonal fluctuation at the time of birth and the acute sleep deprivation of having a newborn. Baby blues does usually occur in the person who gave birth because it is very hormonally influenced. That doesn't mean that dads or non-gestational parents don't get postpartum depression. It's that baby blues is a separate thing. Almost everybody experiences some mood instability after they give birth. It's usually in the first week after delivery. It peaks at about 3 to 5 days postpartum and resolves by 10 to 12 days. So if you think about it, 3 to 5 days, that's like a day or two after you get home from the hospital, unless you're a very lucky person who gets discharged very quickly and are able to go home and, are able to get around and do the things that they need to do. But still, you feel like, okay, things have stabilized a little bit. I'm at my house. And then you get hit with this baby blues. If I draw from my own experience, since I am uh, over a year postpartum now, I remember looking at my newborn sitting in my lap in her little swaddle and feeling so, so sad that she was on the outside of my belly now, that I couldn't keep her safe anymore. And I remember saying that to my husband, who was saying, she's not in danger. I don't understand. Why are you worried about being able to keep her safe? And I couldn't even really explain it. Just was this feeling of she was safer when she was with me. And now that she can be away from me, I'm so, so sad about it. This is a feeling that I have heard from almost every person that I have worked with is immediately after my baby was born, I was hit with this mood change that I couldn't explain that led me to crying over old episodes of Grey's Anatomy, or just hit with anger at my dog licking his foot in the middle of the night, even though I was already up. So these are mood changes that are temporary. They go away within a couple of weeks. They are unpleasant for sure, but they are not at the threshold where we would consider a clinical diagnosis. In the case of baby blues, as a therapist, I would probably encourage some distress tolerance skills, knowing the way that you feel now is not the way that you're going to feel forever, and leaning on your support system. If the baby blues continues, if you notice that your mood continues to be very all over the place, very unpredictable, very uncomfortable, or if it's impeding your ability to take care of yourself or your baby, then we might be talking about something like postpartum depression or postpartum bipolar disorder. So again, the causes of baby blues are typically hormonal. Like we said earlier in this presentation, estrogen and progesterone are the highest they have ever been in a person before they give birth. Part of this is to sustain the pregnancy, to sustain the placenta, which is feeding the fetus. And then those hormones drop to their lowest levels ever in postpartum. That is why you experience things like the bleeding that happens after giving birth, that and a whole human just came out of you. But the bleeding is stimulated by estrogen and progesterone, by the removal of the placenta, and also you experience things like blurry vision, like hair loss, like changes in your breasts. These are all hormonal related changes. Other things that change hormonally include the increase in oxytocin and prolactin, which promote parent and infant bonding and lactation. If you have ever done skin to skin, or if you know parents who have done that, that is when the parent has the new baby on their chest, typically where they can hear their heartbeat, and they have their bare skin against the baby's bare skin, against their little cheek or against their chest and their arms. This helps the baby to bond to their new caregiver. And also in people who are lactating or who want to induce lactation, it induces the release of prolactin, which is a hormone that helps produce breast milk. So those hormones are fluctuating pretty significantly in those early days when you are kind of hunkered down in the hospital or in your house and you are snuggling that baby a lot, trying to bond with them, teach them that you're their caregiver, you're their safe person, and also if you are trying to breastfeed them. Those hormone changes can affect mood lability, so can sleep deprivation. Again, we kind of accept that Sleep disruption is a given when you have a new baby. Um, that said, sleep deprivation does not have to be a given. One of the most impactful things that we can do as therapists with our clients that are expecting a baby is making a plan for protected, uninterrupted sleep, however much they are able to get. And also building in some contingencies, knowing that that sleep plan might not work out perfectly. In fact, it's likely to not work out the way that they've planned. Um, for example, some parents might choose to split the night. I'll sleep from 7 p.m. to midnight, and you'll sleep from midnight to 5, and then we'll meet in the morning and kind of go from there. Some people might choose to supplement with a formula bottle or a bottle of pumped milk overnight so that if they are the lactating parent, they can sleep and their partner who is not lactating can give the baby a bottle overnight. Some babies absolutely reject bottles and will not do that for you. Um, in that case, we might have to figure out, okay, if it's guaranteed that I'm going to have to be the one getting up to feed them in the middle of the night because newborns need to eat every 2 to 3 hours, then where in my day can I get a pocket of protected sleep? Because that sleep is really important to my mental health. So sleep deprivation doesn't have to be a given. One really important thing to keep in mind with all of this is that PMADs are common. Like we said, they're quite prevalent, but they are also very treatable. I mean, as we've been going through this presentation, we've been kind of sprinkling in some ways that we might work with new families. But then why is it that, according to the University of North Carolina and their research initiative into maternal mental health, that 50% of people with PMADs go untreated? So there are a lot of factors that might keep someone from accessing treatment successfully. One is stigma. There is a lot of stigma around asking for mental health help, whether you are a new parent or not. Specific to the perinatal period, again, we don't make a lot of space for new parents in our society to talk about how hard it is. The way that we do talk about new parenthood is often, aren't you just so happy all the time? Aren't you just so blissed out? Aren't you so lucky that your baby is healthy, that your baby is here? All of these things can compound on feeling shame or feeling guilt about these feelings of, yeah, my baby is great, but I don't feel like myself, or I don't feel happy all the time. I feel tired a lot of the time, or I feel sad, or I feel anxious. There's also a lack of awareness of perinatal mental health, both for patients and for providers. I mean, often when people get into the field of perinatal mental health, what they bring with them is their own experience as a patient, as a new parent. It's true for me, it's true for a lot of people that I have known and worked with, that we were not adequately prepared for the experience of being newly postpartum or being um, in the perinatal period, and just how much that can rock your relationship and your sense of self and your identity. There's also not great treatment options available always. While in Ohio, we have a pretty robust support system available clinically for new parents in the perinatal period. Um, Across the US, that is not actually the case. Um, I don't remember exactly what the information was that I found from Postpartum Support International, which is one of the leading organizations treating PMADs and providing outreach and education and resources. But in some states in the US, there are only a handful of outpatient providers who specialize in perinatal mental health. Certainly, there are only maybe a dozen inpatient programs that focus on perinatal mental health. So if you are a new parent in the US and you are experiencing clinical PMAD symptoms that would merit hospitalization or an IOP program, there may not be one in your state. There may not be one in your region. You might have to travel. It might not be covered by your insurance. And it also might not be, it might not be accessible in other ways, like transportation wise. If these treatment options are only housed at specialty facilities, are they on a bus route? Do you have to pay for parking? Um, do you have to walk a long ways to get there? Is there childcare? One of the things that is really shocking as a mental health provider in this space is that a lot of treatment programs for new parents don't offer childcare. It's also pretty common for maybe the generation above me of therapists to absolutely not be okay with children coming to sessions for outpatient mental health therapy. There's a belief among mental health providers that this can really impair the therapeutic rapport between the therapist and the client. But I would argue, and maybe this is just my bias, my approach, my theoretical orientation coming out, I would argue that spending the whole session on my couch, worried about the babysitter that you left your kid with for the first time or the second time or even the 10th time, is also going to affect our relationship and our ability to work together. For those that are interested, there are some really cool trainings available in parent-infant attachment and how to do parent and infant sessions together if you do want to beef up those skills. But also just working with your client to find childcare that they trust and to do that over time, gradual getting used to of utilizing that childcare. Lastly, we touched on finances, we touched on insurance coverage. Not everybody has the ability to pay for treatment or take time off work to go to treatment or pay a babysitter to go to treatment, but also just time. One of the greatest resource deficits in new parenthood is having time to do anything. There was a reel that went viral that somebody sent me recently of a new parent saying, like, I really need someone to help me so that I can take a shower today. It's been 3 or 4 days. And I was thinking that, again, this is all too common, that we get so wrapped up in caring for our children that we forego the things that we need for ourselves, for our basic needs that keep us healthy. Having the time to not only sit for an hour in an office with a therapist, but also drive there, drive back, that's a pretty substantial commitment for a lot of people. And these are things as therapists that we have to be keeping in mind when we are working with new parents. So shifting gears a little bit, let's focus specifically on quote unquote, the other parent, the non-gestational parent. According to the National Institute of Health, about 9% of non-gestational parents experience depression during their partner's pregnancy, and about 8% experienced it during the first year of their child's life. Why is this? This is pretty significant. If we think about rates of depression among men in general, we know that these numbers are underreported. But when we look at partners that did not give birth, when we look at non-gestational parents, this is not a gendered category. This is just people who have kids but didn't give birth to them. That's still about 1 in 10. That's pretty significant. Some of the factors that contribute might be cultural or gender related. For example, the idea that men don't cry. This might lead new fathers to internalize the feelings that they're having. Um, Often, non-gestational parents get less parental leave from their employers, and so they might feel pressure to be fully present at work before they have adjusted to the role of new parenthood. Some of these things are cultural, like the belief that uh, my husband is my rock, or, he is the dad, so he has to be the strong one. I can be the soft one. But then there are also some of these social and cultural situational factors or environmental factors as well. Like, oh, well, you didn't give birth, so you must be able to come back to work sooner. Never mind in a household in 2025 where the domestic labor is being split as evenly as it can be. This parent may not have given birth, but they're also not sleeping. They're also not eating well. They're also feeling like they are, stuck in the house 24/7 when they're not at work. And now you also want them to come in and perform at the level they were before they became a parent. So physically depleted, emotionally depleted, and also huge identity shift. Now I have a person I have to take care of, but I'm back at my desk Monday morning like nothing happened. Um, it's also emerging in the research that many non-gestational parents experience secondary trauma after witnessing their partner and their child go through a complicated birth, or also if their child was in the NICU for any period of time, that again, these internalized symptoms of I can't cry, I have to be strong for them, while being firsthand witnesses or repeatedly exposed to the details of that traumatic experience can be really damaging, can be really difficult. And lastly, we talked about sleep deprivation and nutritional deficiencies. These things don't discriminate. Anybody who has had a new child and is dealing with that huge disruption in their life structure is susceptible to them and the impact they can have on their mental health. Now, expanding a little bit again to look at the intersection of socioeconomic status, race, age, there are some factors to consider that uh, low income women are more likely to experience a PMAD during the perinatal period than women in other socioeconomic categories. About 40% of women who are low income will have a PMAD during the perinatal period. And also, Black women will experience disproportionately higher rates of negative outcomes from PMADs than white women, meaning they are more likely to be inpatient or hospitalized. They are more likely to go untreated or report higher severity of PMADs than white women. And last, we talked about younger parents and how they are at a higher risk of developing a PMAD. Part of this has to do with the stigma of being a young parent, and part of this has to do with having less social support when you are younger. If I put myself in the shoes of uh, someone in late high school and I'm becoming a parent, I not only have to juggle my own coursework and parenting and the physical and mental changes that we just spent this whole hour talking about, but also developmentally, my peers are not in the same place that I am. My peers are not worried about the same things that I'm worried about. They may not know how to support me. They may not be available to support me. So not only do I need more and different support from the people in my life, it may just not be there. Um, the place that I got my start as a social worker is an alternative high school for young moms in Massachusetts. So these were young women that were between the ages of like 14 and 22, and they all had kids under 1, and we're working towards their GED. And part of what that organization tried to do was supplement the places where these young people didn't have support at home or in their communities. And I think the takeaway there is that it is really hard to be young, to be a person of color, and or to be low income, and also be dealing with the expected effects of PMADs. These are things that we know what they are, we know what to look for, we know how to treat, but we can't undo some of these social and cultural factors. We can be aware of them, we can notice how they impact this person's experience, but at the end of the day, there are these systemic elements to the experience of PMADs that as therapists, we also have to be advocates. We also have to acknowledge and work to change these things. So lastly, we're going to end by talking about the impact on the family system. So a little refresher for those of us that have not talked about family systems theory since graduate school. Family systems theory came from the research out of the Bowen Center. They believe that, or this theory believes that the family is an emotional unit, that the system has different members, different parts, all of which affect each other. They have power to influence each other. And so Bowen in the family systems theory says a change in one member of the system creates subsequent changes in other members and the system as a whole. So now if we're thinking about the family when a new child is added, that doesn't just affect each of the parents or the parents and the sibling. This also affects how the system, the whole family, functions. So Bowen's family systems theory has 8 main concepts. We won't get into defining each of them because that, again, could be a whole other psychoeducation presentation. But you'll see in bold on the left here how some of these are especially salient during the perinatal period. So the first that I would highlight would be differentiation of self. Differentiation, I always explain it to clients as the very normative process, expected, appropriate development of children getting older and starting to figure out, who am I when I am not a part of this system? How am I similar and how am I different than my family of origin? In the context of the perinatal period, when we think about things like matrescence for moms and becoming a parent for people of all genders, whether they gave birth or not, there is a differentiation of self from the family system that occurs. For non-gestational parents, this might look like, okay, I know how to be a partner to my spouse. I know how to be a member of my household, but I am now also a parent. I am a dad, or I am responsible for this little person. What does that mean about me? What does that look like? What do I like? What do I not like? What do I need? How might that be similar or different than what I've seen before? There's also a process in Bowen family systems theory called the nuclear family emotional process. This is the process by which members of an immediate nuclear family have the power to influence each other's emotions, whether it's conscious or unconscious. In a new family where a new child has just been added, it's not always conscious or intentional how these emotional interactions or emotional processes affect the members of the system. So the new baby does not know that they are causing you great emotional turmoil by not sleeping or not eating. All they know is, I have a need, I want it met. So far, you've been the guy for the job. So help me out here. That said, the nuclear family emotional process is highly relevant to the perinatal period. The emotions that we experience as members of the family system have an impact on other members of the family. So if I am sleep deprived, not eating well, not able to get time for myself, not doing anything but, you know, changing diapers, making bottles, doing laundry, I am likely to be more highly labile. That might lead to more conflict with the adults in my household, my partner, if my parents are staying with us, might also lead to tense interactions with me and my children, which leads us to the family projection process. This is where the emotions of older family members get projected or kind of transferred onto younger members in the perinatal period by our words and our actions. The most clear example I can give for this projection process in the perinatal period would be in health anxiety, which is quite common in new parents. One of the things that we talked about in my early perinatal mental health training is looking at how often some of our anxious parents are contacting the pediatrician and what about. So while it is normal for new parents to have questions about how do I care for my baby's health, if they are calling quite frequently, if they're calling late at night, if they're calling emergency services with great frequency, if they are coming to in-person visits more often for physical evaluation. These are all signs that we might want to be screening for PMADs, and in particular, postpartum anxiety. If somebody has that postpartum anxiety, what they might be projecting onto the younger members of their family, their children, is fear about the world, fear about their bodies, or a feeling that they are not safe. Again, while it is normal to worry about your child's well-being, it is also quite difficult to grow up and be brave and try new things when you feel like you're not safe to do so. One of the most important things in developing a strong parent-child attachment is being a secure base for your kids, letting them feel like you've got this, that if they go out there and be brave and try new things, that you'll be able to catch them if they fall, quite literally sometimes. So when we're looking at frequency of pediatrician contact, we are looking at just how often are our new parents feeling nervous about their kids' health? Is it warranted? Is it a sign that something is amiss and that we need more medical evaluation? Or is it a sign that they are very worried about other things that are otherwise normal to development and not cause for alarm? So do they need evaluation or do they need reassurance? And lastly, when we look at the multi-generational transmission process, you'll see my like cute grandparents in this graphic here. We're talking about family patterns, extended family patterns. So how your parents parented you and how you parent your kids. During the perinatal period is where we typically see the kind of beginning of grandparents offering their parenting advice for a lot of families. And depending on the parents' relationship with their parents, that can be challenging and can be impactful on mental health. When let's say your kiddo does have some health concerns. Let's say it's a difficulty with feeding in a newborn. And you might be of the mind that, once a month visits with our pediatrician and the lactation specialist is good enough. That feels like the plan that my co-parent and I have decided upon. That's what we're doing. Now, if grandparents are coming in and they are feeling anxious about that plan, they might be making comments like, well, are you sure you don't want to get a second opinion? Or, in my day, we didn't have lactation consultants, which is not true. They have always existed. They just weren't always called that, but whatever. You might be hearing some of these unsolicited opinions. From there, we're passing down grandparents' anxiety about health to parents' anxiety about health and parents' self-doubt in their burgeoning, developing judgment as parents. Now, kids are noticing the difference in attachment with their parents, even as little babies. They're noticing my caregiver seems kind of nervous about something, and it makes me feel less settled. This is not to put greater pressure on new parents because there's certainly enough of that. This is to say that the family is impactful. The family system is impactful in the perinatal period. So again, family bonding and attachment is one of the big things that we are looking for here. Is how is family bonding and family attachment impacted? So babies give us cues to respond to their needs. They do things like make certain noises, make certain expressions, move their bodies in certain ways to tell us what they want and need. Having PMADs may make new parents less responsive to these things or less able to recognize those cues. This is not a judgment of new parents. This is just a thing that might happen. Poor parental mental health can impact child development if left untreated. Can impact not just the bond, but over time can cause poor communication or conflict between parents. Can also make it difficult for parents to recognize their kids' cues as they get older too. So even as kids, learn baby sign language more and milk or whatever they're teaching them in childcare settings these days, they might not be able to retain that information because the way that PMADs affect parents' short-term memory or even long-term memory. How much milk am I supposed to be making for overnight bottles again? What did we decide? Sometimes when our mental health is bad, our executive function and our cognitive reasoning is impaired. Poor mood regulation is another impact, is also impacted by untreated PMADs. Child development of mood regulation starts with co-regulation. So we are our children's first teachers, which is an intimidating thought. We hand you this new baby and we say to you, you're the one that's supposed to teach them how to regulate their mood, how to respond to distress, and how to help themselves calm down. But we're also handing you this baby during like one of the most physically and emotionally unstable periods of your life. Again, this is a lot of pressure for new parents. We think about the social and cultural factors. So our kids are teeny tiny little pattern absorbers. I'll never forget when I heard that in a training many years ago now. They learn first by observing and then by imitating. Unintentionally, this can lead to some not so helpful behaviors and habits in kids. So if they are seeing that whenever we are overstimulated, we yell, they are going to imitate. They are going to see us yelling and they are going to think yelling is what I do when I'm mad. By the time your new baby becomes a toddler, that can start to be a little bit of a problem for the household. Now everybody's yelling. When your co-parent comes home and everybody is yelling, They are activated by the loud volume and by the impression that everybody's mad. And now nobody feels regulated. Nobody is okay. That said, this poor mood regulation, poor co-regulation, unintentionally can lead to codependency, difficulty tolerating each other's or others' emotions, or parentification of children can lead to kids feeling like, I have to be good so that my parent doesn't yell. I have to act a certain way so that their mood stays neutral and so that I can be neutral. It's never our kids' jobs to take care of our emotions. And this is, for many of us, one of the hardest parts of parenting. So when you are working with parents in the perinatal period, while we don't want to give them inappropriate guilt for how difficult this work is, we do want to raise the flag that your kids are watching. And we want to help you take care of yourself primarily because you deserve to be taken care of. Secondarily, because you have a big job of taking care of them and they are learning from what you're doing, whether they're learning good things or not. Bowen in family systems theory calls co-regulation part of emotional interdependence, that in the family system, we hold great power and influence over each other. And that in a family system, whether we want it to be this way or not, our emotions do affect each other. So if I am angry and I yell and my kid sees me yelling and they start yelling and we're all angry now, and then dad gets home and all three of us are yelling, that is a normal and expected part of that system interdependence. The same way that if I get angry and I go to yell and I remember what's going to happen because I've been there before, and instead I, smell the flower, blow out the candle. My kid is going to see me doing that. And maybe the first, second, third time, they're not going to imitate me, but after enough practice, they're going to do the same thing. After enough practice, maybe 1 out of 3 times that I get overstimulated and want to yell, it won't become a big blow up. Maybe after a couple years of practicing this, it rarely becomes a big blow up. That's what developing mood regulation skills with new parents looks like or can look like. So how can we help? We have a little time left, so this is where we'll end today. For friends and family of newly postpartum parents or people in the perinatal period, we can familiarize ourselves with signs and symptoms to watch out for now. Even in early pregnancy, it can be a good idea to keep an eye out for some of those things that we talked about, those red flags for PMADs. For people in support systems, we can also offer practical and tangible help during the postpartum period. Things like, can I do a chore for you? Can I make a meal for you? Can I be the one helping you protect some sleep on Saturday, on Wednesday, on my day off? Checking in often, even if you don't always get a response. It is a-okay to leave a voicemail, leave a voice memo, send a text thinking of you, hope you're having a good day. Here's a cute thing I saw today that made me think of you. And remind your perinatal friends and family members in this postpartum period to connect with others, even if it's brief. Even if they make it out of the house with the baby for 20 minutes to walk up the street and meet you at a coffee shop, that is great. Even if they answer the phone and can only chat for 5 minutes before all hell breaks loose and they have to hang up, also great. The key is to be a support and remind them that they are not alone. For providers, not only do we want to know the signs and symptoms early, we want to be talking about risk factors and signs and symptoms of PMADs quite early. During pregnancy is the best time. We want people to know that, know not only what are the things to be looking out for, but also to know that we are knowledgeable and that we're comfortable talking about this with them. Um, a lot of clients that I have worked with have had the fear that if I talk about being depressed or anxious, then my provider is going to get me in trouble somehow. And part of that is on us, that providers have a uh, colorful history of being mandated reporters and sometimes um, being, I guess, not always the most judicious users of information about our clients. There is a history of social workers and therapists using vulnerable clients' information in ways that is harmful to them. So there is a valid fear from clients. If I open up, will I be unsafe? Our goal should be to let them know that they are safe with us, that they can talk about PMADs, that they can talk about the scary things, whether it's postpartum depression, anxiety, OCD, or even postpartum psychosis, that we understand that these things do not mean that you want bad things to happen to your child or to your family, that they mean that you are having a mental health crisis or you are having a mental health problem and that you need help from us, that that is why you are talking to us about this. So how do we do this? We screen early and often. Might be overzealous to some, but I would argue if you're seeing them once a month, do it once a month. If you're seeing them every 2 weeks, do it every 2 weeks. Screen both parents, not just the pregnant person, if you're treating a couple, that is, or if you see both parents at any point. Help them create a plan for postpartum sleep protection. So whether they are the gestational parent or not, they need to have a plan for how am I going to get rest when this little person is here? And also normalize this experience for your patients. I gave you a ton of prevalence statistics, so you know that this is a common thing that happens to people. Use of self might be helpful here. If you're comfortable disclosing a little bit of what your experience in the perinatal period was like, then that can help people to feel like, oh, I'm not alone with this. If my doctor, if my therapist, if this person that I think pretty highly of has been here as well, then I must not be the only one. You'll notice that I sprinkled little bits of my story in here as well. That was intentional. Again, I want my clients, I want the people that I work with to know that just because I do this for a living doesn't mean that I was great when I was going through it myself. It is a difficult, difficult thing to give birth to a whole person and then be entrusted with their care and deal with all of the transition that comes with that period. So lastly, I want to leave you with some resources for your clients, for yourselves. First is Postpartum Support International, which is a fantastic resource for any parent going through the perinatal period. They have support groups online, completely free, amazing resource. They're happening every single day of the week. They also have a 24/7 chat or phone line. They offer a good number of educational resources. So if you want to read more about anything we've talked about today, in Ohio, we have a specific postpartum support organization called POEM. It's through Mental Health America of Ohio. They also offer free support groups operating most days of the week. And lastly, I really like the resource MomWell. Again, kind of like gendery language, but they are not only for women. They certainly don't have to be only for women or only for moms. They have a website, they have a podcast. I believe the founder has written a book as well. They have a really useful PDF for thinking through things like your postpartum support plan, which I use often with my clients. So these are some resources to leave you with today. And lastly, I just talked and talked and talked for like an hour and a half. So I wanted to pause and say thank you for being such a great audience, and leave some room for questions if there are any.
Thank you so much. I'm going to go ahead and